This presentation is about ventricular assist devices. Typically we encounter those that are left ventricular assist device, or an LVAD, although there certainly are right ventricular assist devices, and then there are devices for both ventricles known as BiVADs. This is not particularly new technology. More and more of these are showing up as time goes on. There's about 5,000 of them that were implanted to date when this presentation was made. I borrowed these slides and images, or excerpted them from a presentation that Mike McAvoy gave at a national EMS conference, and these were some of the images that he used. And one of the things he wanted to point out was that there are quite a few of those out there, and we're seeing them more and more in our local area. The device is battery powered, has a number of components on the outside, and then there is a catheter that goes through the patient's abdominal wall to the implanted pump. Here's a schematic of where the device sits, usually in the patient's left upper abdomen, and so that it can attach to both the aorta and the left ventricle or the right ventricle, or whichever ventricles it's trying to assist. And then the catheter, supply line, control line, tubing comes out of the patient somewhere in the midline, or more often toward the right abdominal area. Here's an x-ray giving you an idea of where the device sits internally, and you can see control line is pretty much radio opaque there, coming out toward the patient's right side, as well as the pump components and where they sit in relation to external anatomy. Here's a picture of the supply line as it exits the patient's abdomen, usually on the right side. You can see the large scar there for the midline sternotomy that was in place. And typically this site's going to have dressings on it, and that dressing and wound care there is a key issue for the patient to avoid infection. The device itself is very simple, just has the one moving part, a rotor that assists the ventricle, and these obviously are used in patients who have severe heart failure to where their ventricles simply are not able to pump efficiently any longer. And the very simple design, the one moving part, obviously is a key thing. Still, it is dependent upon batteries and the control unit, and so these patients can lead relatively normal lives, very active lives, and in the rest of the videos that we've attached with our lesson that accompanies this presentation, you can see how those patients move around and do quite well. But there are a lot of mechanical restraints here, and the batteries are a key component, obviously. Another closer view of what the external controller unit looks like, and how patients typically wear it. It clips on a belt, or they can wear it in a sling, and then the two batteries usually hang around their shoulders. Here's another view of a patient wearing one of the LVAD devices with the battery pack and controller in something like a fanny pack that then has a sling for the shoulder strap. The equipment's relatively heavy, and so most of these patients will be wearing something that does allow their shoulders to help them. Again, it's a battery-powered device, and therefore patients are dependent upon reliable battery technology, and all of us realize that anything that runs on batteries can have issues. They do have a backup battery with them, and a charging system, and all the usual things, the same sorts of equipment that we keep with us to keep our battery-powered units alive. Here's the system controller itself. Obviously there's a backup to that as well. Again, a simple device, but certainly critical to that patient's well-being. Some of the older devices had a hand pump. I'm told that the newer devices do not. Their reliability is such that apparently they are very reliable, but the hand pump would have been a way to work for the patient's heart should the batteries die. And in any case, they keep extra batteries, and any backup pump that will be available for the device, they keep those with them, and they're very concerned about that, very dependent on that entire supply of materials and equipment. The machine, very simple. It's a rotor, it's a rotary pump. We'll talk about that in a minute in terms of how that flows and how that affects our assessment. but it is a one-way blood flow, simple rotary pump. This is probably one of the key, if not the key thing for us to understand as field providers. These patients don't have pulses. They're alive, but they don't have a pulse. The pump, the machine, is a rotary pump, and it does not generate any sort of pulse. It simply generates flow. And so these patients have a little bit of a different assessment, and we'll talk about that more here in a second. Your non-invasive blood pressure machine, as well as your normal auscultated manual blood pressure, are not going to be obtainable or accurate in patients like this because there is no pulsatile flow in both of those devices. Whether you're listening to it or having the machine pick up the pressure depends on that pulsatile flow. The Doppler, however, does offer you an option to get blood pressure measurements. It's a picture of a patient with his large, rather impressive sternotomy scar, similar to that of a coronary bypass. This is obviously quite a traumatic procedure to have this in place, and patients have significant scars from that. So that may be a hint to you, although it would seem rather obvious to me that you won't need many hints. There'll be quite a bit of equipment, battery packs and such with these patients. But this does involve an open chest procedure to place this. Obviously, it is significant surgery. Again, the hints are going to be there for you. It's pretty obvious that this gentleman has quite a bit of equipment with him, as well as the large scars. Another view of a patient with an LVAD, and in this case, he's got the equipment hanging on his left side. Most of the other pictures are showing it on the right side. Obviously, they can move those around, and it appears that his control line enters pretty much in his right axillary area, which is a little different than some of the other pictures, so I wanted to include this one as well. Apparently the next generation is coming out with a transcutaneous charging of an implanted battery option, which would be an amazing improvement, I would think. If I were an LVAD patient, I wouldn't want to have to drag those batteries around all the time. And so they would have implanted batteries and be able to charge through the skin, a very amazing potential advantage of that. And so there's more things happening all the time. More and more patients are needing these, and there's quite a bit of technology that's changing at a rapid rate. We'll do our best to keep you up on any new developments there that we come across. As far as patient care goes, again, these patients will not have a pulse. But in addition to that, for the paramedics out there, these folks are tremendously preload dependent. And so fluid volume may be one of our most important, if not our only tool to help these people. Their EKG is not as important. There must be a rhythm, but whether it's atrial fib or whether it's an SVT or whatever is less important. The machine operates regardless of what the cardiac rhythm is. But remember, it's not replacing the heart, it's assisting the heart. So it needs the heart to be producing legitimate output, even though it's at a reduced level. They're also very afterload sensitive. These patients will be, from a perfusion standpoint, challenging, complex for us to manage. And obviously these patients are also heavily anticoagulated, so significant risk of clots and such. And so when an LVAD patient falls, or when an LVAD patient is involved in trauma, they are heavily anticoagulated, and they're going to bleed more from the same injury that someone else would not bleed so much from, and they're more likely to have significant bleeding from relatively minor injuries. Prone to infection, prone to blood clots, and obviously the risk of stroke goes along with that. And then there's all the issues with that pump and its malfunction. But the key thing is that these folks do not generate pulses, and so a lot of our perfusion is based on whether or not there is a pulse, and we're going to have to look at EKGs and measure blood pressures with Dopplers. Skin condition should still be a good clue for us. The LVAD patient who's diaphoretic is in trouble, the same as the patient without an LVAD who's diaphoretic is in trouble. Treatment guidelines for these patients when they're in a shockable rhythm, a VTAC or a VFib. The pump may still be generating some flow, and so you may have your person looking at you in a rhythm that you would normally not associate with the patient maintaining consciousness. The pump speed and flow may be normal, or it may be low normal, depending on what type of output the heart is still able to come up with. Cardioversion, as well as unsynchronized cardioversion or defibrillation, those are all reasonable. And they're talking about, they mentioned the term contact the VAD center. Our experience tells us that these patients will have phone numbers for us to call for expert consultation, and there should be someone available to us to guide us through these. As they become more and more common, we may have more of a comfort level, but I personally can say that I am not at all comfortable with this situation, and I would be very happy to have someone on the other end of the phone who could give me some guidance. So this is the last screen, kind of a summary screen. Don't be messing with the equipment, obviously. You're going to need a Doppler for your blood pressure. They have reasonable mean arterial pressures, but they run a little bit low. Their pulse oximetry is unlikely to be accurate because, again, it's based on pulsatile flow. Your non-invasive blood pressure and your manual auscultated blood pressure will be inaccurate or unobtainable. These patients do not get CPR. CPR is not going to be of any assistance, and it's quite likely that normal CPR, and particularly mechanical CPR, would be totally contraindicated in these patients. Immediately obtain some trained assistance. The family's all about helping you make that contact that VAD center, and McAvoy makes the comment at the bottom that online medical control is unlikely to be helpful and may waste time. I think that I'm still going to need to be talking to someone here locally, but the VAD center may offer me more specific advice on how to deal with this patient. These are not patients that I'm going to feel like I need to run to the hospital with very quickly, because a chaotic transport is more likely to cause us problems with equipment. What I need to do is sit still and get some expert advice on the phone and try to manage this patient. I just don't believe there's any magic that anyone has at the ER for these very complex and specialized patients, particularly in our area. Perhaps if you're transporting the patient to the VAD center that's 3 miles down the road from where he had his device implanted, that might make some difference. But until there are patients who are from a VAD center here near us, I think it makes a lot of sense to sit still. So these are very different, very interesting, amazing devices, and they provide a few challenges for us.